Good evening, or depending where you're tuning in from, good afternoon or good morning. My name is Lauren Stiles. I am the president and co-founder of Dysautonomia International. Thank you for joining us this evening. We have Kate Morgan from Australia with us. Kate is a registered nurse and a PhD candidate with the University of Newcastle in Australia. She's studying the experience of pregnancy in POTS, and she has clinical experience working in cardiology and neurology settings, as well as research experience with cardiology trials. Kate has a personal and professional interest in POTS, having cared for women with POTS in the clinical setting. When she's not studying, Kate wants you to know she likes bunnies, baking, and hanging out with her baby daughter. And so without further ado, I will turn over the seminar to Kate, and then after Kate's presentation, we'll take some Q&A. You can ask questions along the way on the webinar control panel, which is probably on the left side of your screen. There should be a little place to type in questions. So at the end of the webinar, we'll go over as many of those as time allows. All right, Kate, give it a go.
Thanks, Lauren. So everyone can still hear me. And sorry about that bio. I wasn't really entirely sure what I should say. So thank you, everybody, for coming to today's webinar on POTS and pregnancy. And good evening to most of you, I suppose. It is a sunny afternoon here at 2 p.m. in Newcastle. No, it's 1 p.m. I get my time zones mixed up. So today we'll be looking at a review of the research surrounding POTS and pregnancy, and also looking at my research study I'm doing for my PhD. So in case anyone's wondering where Newcastle is, there's a big arrow pointing to Newcastle. We're 2 hours north of Sydney on the beach, and it's a pretty fantastic place to be. And these are just some of the views I get from my office window, or I wish. So this is just a picture of beautiful Newcastle, where I'm from, and this is actually where I work. And the view actually from our office windows is of lots of gum trees, and there may even be koalas, but I haven't actually seen one. Hopefully there is. So, on to the actual things. So today we'll be looking at what is POTS. We'll be briefly just going over that. We're assuming that the majority of people attending today are going to have an idea of what POTS is. We're going to be looking what's currently known about POTS and pregnancy, a brief overview of some related conditions and pregnancy, and the POTS Mamas study, what we've learned so far and where to next. So what is POTS? POTS is a condition of the autonomic nervous system, and it's 5 times more likely to affect women, and it most often occurs in childbearing age, which makes pregnancy a really relevant and important thing that we must consider. There's no real statistics, no hard statistics, but it is estimated that between 500,000 and 3 million Americans are affected, which shows it isn't rare. And misdiagnosis is, unfortunately, still common. So symptoms are characterised by a wide variety of orthostatic intolerance, including orthostatic intolerance, cognitive dysfunction, gastro symptoms, fatigue, lightheadedness, syncope, temperature, I've forgotten the word, brain fog is another symptom that we get, but I'm sure you all know these symptoms. And it can cause varying degrees of functional impairment. And interestingly, and what I try to be teaching everyone over here, is that functional disability is similar to congestive heart failure and chronic obstructive pulmonary disease, which are conditions that mostly affect older people, which again shows that in our younger population, pregnancy is a real concern. And POTS can occur without warning. So in regards to POTS and pregnancy, there is basically very little research on POTS and pregnancy around in the literature. Most of the research currently focuses on diagnosis and management of POTS, which is really, really important, but we still need some more information on POTS and pregnancy. And there are currently no guidelines for treatment and management of pregnancy in the setting of pre-existing POTS, which is really concerning for both our patients and clinicians, because we're not entirely sure what medications are safe and what we should be doing to be able to appropriately care for these women and create a positive and supportive pregnancy experience. So we really need to know more, and we need to know more so, as I said, we can understand the experience, so we can improve care, so we can create treatment and management guidelines, and also so we can avoid confusion, which some of you may have seen, particularly in the blogs and the online forums. There are so many varying opinions between what specialists and doctors have said, what people have read, and there is no clear-cut consensus on what is the appropriate treatment and management, particularly surrounding medications. So for my research, once we decided to do POTS and pregnancy, we thought we'd have a look at what is currently known. So to do that, we've conducted a systematic review, which is the most unbiased kind of review and comprehensive review that you can do. It looks at academic journals and as well as the lay literature, which is more of the less scholarly, and pretty much looks at anything and everything that's written about POTS and pregnancy. And our aims were, as you can see on the screen, to evaluate the quality of the evidence available surrounding pre-existing POTS and pregnancy, and to determine what's currently known about pre-existing POTS and pregnancy, and to, importantly, identify opportunities for further research. And we included every paper that we could find, which we thought was important since there isn't any reviews done before. And this review is currently under review at one of the peer-reviewed journals. So watch this space. Once it's published, we'll be letting Lauren and Dysautonomia International know, so we can make it available for you and your treating teams. So what we found was there were 17 publications available. 12 of them had full text and 5 were abstracts. And one of them didn't meet our inclusion criteria because the woman in the case study was diagnosed with POTS in the postpartum period. And we feel that the treatment is potentially different in that case. So we included a total of 11 articles. So I'm just going to talk around this slide for a bit now, and we'll just go over the 5 key areas that we found in the literature. So area 1 was the symptom course during pregnancy, and 8 of the 11 studies addressed this. It showed that there was a variable course of POTS symptoms during pregnancy. There was a general trend towards feeling better in the first trimester. Sorry, please forgive me that was wrong. There was an exacerbation of symptoms in the first trimester, improvement in the second trimester, and symptoms really varied in the third trimester and postpartum period. 2 of the studies reported more than half of their patients remained either stable or experienced improved symptoms during pregnancy, but both studies found less than half of their patients experienced worsening of symptoms, so that's good to know. We feel that improvements during pregnancy to the POTS symptoms might be because of the natural increase in fluid and plasma that just naturally occurs during pregnancy, and that also helps with increasing cardiac output and blood pressure, and that's particularly seen in the later trimesters. So 4 of these 8 studies also address the postpartum period. At 6 months, it was shown that more than half the patients were either stable or reported improved symptoms. And one of the studies looked at 1 year, and they showed that the majority of their patients felt their symptoms were either unchanged or had actually become worse. So the main thing to remember with symptoms is it's very variable, which surprising or is unsurprising given the nature of POTS itself. So the second area that we looked at, or the key area, was medication use. And 10 of the 11 studies addressed this, and overwhelmingly it showed that there are no current guidelines and no consensus on the appropriate treatment and medication usage. So medications do appear to be safe under close observation when the benefits outweigh the risks, and that's something that you can work with your treating teams, obstetricians and cardiologists, to decide whether that's right for each individual. Medications included in the review included beta blockers, propranolol and metoprolol, fluticasone, midodrine, pyridostigmine, and selective serotonin reuptake inhibitors. And it was recommended that propranolol be the first-line treatment because it has a very safe profile in pregnancy and lactation. No studies reported any adverse effects due to medications. And interestingly, we saw that patients who continued medications during pregnancy reported either stable symptoms and less exacerbations, and patients who didn't require medications prior to pregnancy were less likely to report exacerbations and less likely to require new treatment. Which kind of suggests that if you are on medications beforehand, continuing on some medications, obviously in consultation with your treating teams, may actually be beneficial for maintaining symptoms and having a fairly or a smoother course of pregnancy. And also one other thing to note is beta blockers are known to cause low birth weight. So whilst they have particularly propranolol and metoprolol, there's a lot of research into their safety profiles in pregnancy. If they're chosen to be used, you do need to have, or it is recommended to have regular fetal assessments just to check birth weight. And that's something that treating teams and obstetricians will be totally all over. So key area 3 was anaesthesia and analgesia during delivery, and pardon my Australian spelling of this. So 7 of the 11 studies addressed this, and their overarching recommendation was to consult with an anaesthetist or an anaesthesiologist during pregnancy to set up a management plan. So if the research showed that early analgesia with close monitoring of blood pressure and heart rate may reduce tachycardia and associated complications during delivery. Epidural was the preferred method with phenylephrine, and that can help prevent reactive tachycardia in the presence of peripheral vasodilation causing hypotension. Fluid loading may be useful, and of course close monitoring during labour is essential to avoid unnecessary interventions or delays in appropriate management of pain and associated hemodynamic changes. And one of the studies actually described 2 patients who delivered successfully without complications and without anaesthesia or analgesia during delivery, which is great if that's not your thing. So area 4 was mode of delivery, and 6 of the 11 studies addressed this. And they showed that there are no current guidelines for delivery method. The very first case study that was reported in 2005 recommended caesarean section, but subsequent studies have shown that that's not actually necessary and that vaginal delivery should be safe with appropriate planning. And mode of delivery should be based on obstetric indications, not POTS. So if you have POTS, it is possible to deliver vaginally with appropriate management plan. And area 5 was complications and adverse events, and 7 of the 11 studies addressed this. And they found that complications and adverse event rates were similar to that of the general public. There was one study that showed slightly higher rates of miscarriage and hyperemesis gravidarum. And there was, interestingly, a large number of general complications and adverse events which was reported. The literature suggested that none of these were caused by POTS, but we do definitely need some more research into this to find out, or to show that POTS really isn't causing these things. So as it stands currently, it seems that POTS shouldn't be considered a contraindication to pregnancy, which is great. So the other thing that we did with our systematic review was we appraised the quality of all the papers, which is using the McMaster's critical review form and the NHMRC evidence grading matrix, and we found that the overall quality was poor, and this was because they're case studies. So unfortunately there are no large trials, as with POTS in general. There are no large trials and there are no big studies, so making generalisations is really, really difficult. But it is really handy to know what has worked for some people in the past, and case studies are useful for that. So the take-home message for everyone is you might actually feel a bit better being pregnant because of the natural effects of pregnancy with the increased fluid. Don't be afraid to take medications if needed. Under close supervision and with your treating team, they are worth it if you need them. And remember that each patient is individual and will need an individualised treatment and management plan for pregnancy, labour and delivery. What works for somebody else may not work for you. Everyone's experience and situation is different. And that's one of the hard things with POTS. We all come from different symptoms, different medications, different treatment plans. So please don't compare your pregnancy experience with anybody else's. And the good news is it would appear that pregnancy does appear to be safe with POTS. So we can all go forth and reproduce. So key knowledge gaps that we found where there were no insights into the women's experience. There were no insights into the difficulties in treating pregnant women with POTS, and there were no guidelines for treatment and management of POTS. So all of these things we really need to look more into, because we know from clinical experience and from anecdotal evidence and from what we hear from patients and healthcare professionals that people are really confused and uncertain of what the appropriate management is. So we need to find out a bit more about this, and hopefully this is when my research will come in. So the next few slides are based on questions that we got from the Dysautonomia International Conference back in July. And I need to just emphasise that these are not my area of expertise. So EDS, we're going to look at EDS, neurocardiogenic syncope, OI, and hormones. They were questions that come up a lot. So I'm going to give you a brief overview of what I found, but yes, not my area of expertise, but very, very interesting and well worth researching. So I really need to thank Shani Weber at the EDS Society for her help on this slide. And I urge anyone with EDS to contact the EDS Society if you like any more information. They're wonderful people, very knowledgeable and very, very friendly. So what I have learned about POTS and EDS and pregnancy is that POTS and dysautonomia is actually quite common with people with EDS, and unfortunately, like POTS, it remains very underdiagnosed, and recognition remains really poor, even with doctors who just don't know what EDS or dysautonomia is. There are many different subtypes of EDS, as you probably know, and they all affect pregnancy quite differently. So it is really important that if you do have EDS, to work with your treating teams and to talk with your obstetricians and your specialists to work out what is going to be appropriate for your particular type of EDS and dysautonomia. So a few of the women in my systematic review were also described to have EDS as well as POTS, but it wasn't actually separated out which women had EDS and which symptoms and were attributed to POTS and which went to EDS. So there still remains very, very little info specifically into EDS, POTS and pregnancy, and when I did a bit of a review of the literature, we didn't find very much at all. So EDS is genetic, and it may affect the baby, and therefore it may also affect the pregnancy. Particularly, it may cause premature delivery, abnormal fetal position, and premature rupture of membranes. So something to keep in mind. And the vascular EDS has been shown to potentially have higher risk for complications than the non-vascular subtype. And some of the complications that were commonly seen, so EDS Society provided me with these 3 links, so feel free to go and have a look at these. They're actually quite interesting. And these results are from the research topics pregnancy survey results. So some of the complications in that I commonly saw that were higher than the general population were premature delivery between 24 and 36 weeks, poor episiotomy healing, joint instability and dislocation, ineffective epidural and topical pain relief, postpartum hemorrhage, premature rupture of membranes, and interestingly, it showed high rates of miscarriage in the second trimester in the classical EDS group. Obviously, pregnancy can cause an exacerbation of normal EDS symptoms, as it does with POTS symptoms. And in vascular EDS, there has been reports of organ rupture or dissections. So if you have POTS and EDS and you are pregnant or thinking about falling pregnant, please see your EDS specialist or your POTS specialist and consider seeing a high-risk obstetrician to get their opinion. So the next little subtopic was neurocardiogenic syncope, also known as vasovagal syncope, and orthostatic intolerance and their effects on pregnancy. So again, this is not my area of expertise, and there is again very little data available, but the general principles are very similar to POTS in this group. So there were two case reports for neurocardiogenic syncope for 3 patients in the UK found, and they suggested, as it is with POTS, a team management approach between obstetrics, anaesthetics, midwifery and cardiology. It obviously, particularly with vasovagal syncope, can be very challenging for anaesthetists, particularly in delivery when you've got stress and needles and blood involved, which are common factors that cause people to have casual vasovagal syncopes. There was some information that I found, very limited information, on vasovagal syncope in delivery, but it wasn't particularly helpful as there was no medical history described, and the other one was a patient who had injection-induced vasovagal syncope. So the general principles really remain the same, and there was no specific information on orthostatic intolerance in pregnancy, but again, the treatment and management is very similar to that of POTS. So yes. So the next, the other question that we got asked a lot of was POTS and hormones and how that all links together. And again, not my area of expertise, but a very, very important and interesting area that needs more research. So I did find one study by Pegs et al. It's a US study from 2012, and they showed that there was increased lightheadedness through all phases of the menstrual cycle as compared with healthy controls. There's a higher incidence of estrogen-related gynecological diseases as compared with healthy controls, and these may relate to changes in estrogen levels. And they also found a significantly higher incidence of uterine fibroids, dysfunctional uterine bleeding, ovarian cysts, endometriosis, and galactorrhea, which is interesting and definitely needs to be looked into more. So I guess the general conclusion or thought may be that yes, hormones can affect conception and pregnancy, particularly if there is higher rates of estrogen-related gynecological diseases that may prevent or affect conception. And there is no data specifically on POTS and fertility, on hormone replacement therapy, on IVF, or on contraception, which is the most appropriate to use. And if I have actually missed anything, and if anyone does know anything about these topics, these three in particular, please let me know. This is just what I found, but all very, very interesting and definitely needs more research. So now we'll just go a little bit into my study, which is the POTS Mamas study, and we're aiming to explore experiences of pregnancy with POTS and hopefully have everyone have a smiley, preggy belly. So these are my research aims and questions, which I will let you to read. But essentially we just want to know what the experience is for pregnancy with women with POTS and how treating professionals feel about this as well. We think that this is a really good starting point in an area where there is no research. If we can identify from your perspective, from our patients' perspective, from the women's perspective, where we are falling down as clinicians and where we can improve, we can certainly help direct future research endeavours in those areas. And the other really good thing with this research is it's directly translatable right now. So as we get more information from our wonderful participants, we'll be able to publish more results and talk to the clinicians and hopefully be able to make real-time change as opposed to having to wait years and years and years. So we are currently recruiting women with POTS and healthcare professionals. So if you fit this criteria, please let me know. Or if you know anyone that does, let them know. So we're looking for women with POTS who are aged between 18 and 40 years. And POTS must be diagnosed before conception. And we're only looking at first pregnancy resulting in a live birth within 12 months of consent. And unfortunately for a PhD, it has to be quite a small project, but certainly after we've done this study, I would like to open it up and be looking at differences between treatment of women who are diagnosed during or after pregnancy as well. So if you would like to participate, we're looking at just register interest, which is the link below, and complete a short online questionnaire, and it's just collecting information on basic demographics and basic information about pregnancy. And then we're going to interview our wonderful women for a chat to discuss the experience of pregnancy with POTS. And our second group are our healthcare professionals, and we just want to talk to any registered healthcare professional who's cared for a pregnant woman with POTS within the past 24 months. And again, the requirements are the same. We're collecting basic demographic details of how many women these healthcare professionals have treated and what specialty they are. And then hopefully conducting an interview with our healthcare professionals to find out their experiences of treating pregnant women with POTS and any recommendations they may have to improve care. And the number of people we're recruiting will really depend on how many people are interested and come to us. Yeah. Hopefully, the more the merrier. The more we can find out, the better. And so these are our recruitment flyers, which you may have seen floating about. And hopefully, we'll get Dysautonomia International and POTS UK to do another recruitment push. So if you do happen to see them floating around online, particularly in social media, please pass them on to all the groups you belong to, or tell your friends, family, and particularly any treating physicians that you know, or if anyone listening are healthcare professionals, if you've treated someone with POTS, please let us know. So what we've learned so far from the study is that the literature seems to be about right. So far, we've learnt that women have a very variable course during pregnancy. No one's had it smooth sailing, or everyone's pretty much felt worse in the beginning of pregnancy and felt a bit better in the middle, and it's been varied so far toward the end. We've learnt that people have complications. We've learnt that our women have seen a variety of different kinds of specialists, from midwifery to high-risk obstetric care. And pretty much it's just all unknown. Everybody seems to just be treated as we all treat POTS. It's all very trial and error and guesswork, unfortunately, or a lot of guesswork anyway. So importantly, where do we go from here? And this is something too that our research study will hopefully help inform. But there really needs to be more research in the future on POTS and pregnancy. And these are just some of the ideas that we've come up with so far. So we really need to look at, compare the treatment of women with a pre-diagnosis of POTS and those who were diagnosed during pregnancy or postpartum. Just having that label of POTS when you're pregnant for healthcare professionals that don't understand POTS properly, does that actually adversely affect your treatment? Or does it actually make things easier? Because I know it's not just normal pregnancy symptoms making you feel a bit worse. We also need to investigate short and long-term effects of pregnancy on POTS. There still is no data, and from anecdotal evidence, we know that some people feel great after pregnancy, some people feel really rubbish. Subsequent pregnancies can be totally different. Some people can almost be cured, dare I say. But it's all so varied, and we're not really quite sure why it affects each person so differently. So that would be really interesting to look at what the course actually is like in the long term. There is no evidence on breastfeeding and how that affects POTS, and that's something that quite commonly comes up from patients as well. We need to also look at symptom exacerbations, and medications is a really big one, particularly in medications. A lot of the medications commonly used for POTS are really under researched just in the normal realm of things. So ivermectin, for example, has very little evidence on, or no evidence, human evidence from what I could find, on its effects of pregnancy and breastfeeding. So that's a great medication for some people, but unfortunately it's one that you just wouldn't even try in pregnancy, whereas things like propranolol and metoprolol we know a lot about. So just looking at the range of the common medications used in POTS and see how they do actually affect pregnancy and the developing fetus. And also looking more at the complications. As I said before, there was that long list of complications that seemed to be general complications, but we need to look more about why these complications did occur in the groups, and particularly with miscarriage and hyperemesis gravidarum, which was shown to be slightly higher. Is there actually a correlation between those and POTS, or is it just something else? So lots of things that we need to do in the future, and this is all things that you guys can all help us with as well. So for more information, Dysautonomia International has a fabulous, all sorts of information on all sorts of different things, so they're an excellent resource to go to. POTS UK similarly. They also have a little pregnancy section on their website, EDS Society, as I said before. And I have recently joined Twitter. I'm still not very good at using it, but we will be posting updates on the research and what we're doing here in the land of Oz, and we'll be presenting also when we've got results or published papers, or when we're doing things like this, we'll be advertising through Twitter as well. So if you're on Twitter, feel free to follow and You can keep updated on the Potsy Mamas study. And just acknowledging as a student, my supervisors who are fabulous, and I've been educating them on POTS and dysautonomia, and they also are very enthusiastic, which is great, spreading the word down here. And Lauren has been a fantastic support and guide for me right from the beginning. And Shani Weber, as I said, from EDS Society, educating me on EDS. And most importantly, our wonderful POTS community, because without you guys, we wouldn't have this research, and without you guys, we wouldn't be able to do any of the research that we do. You make it possible, and please keep all ideas and your participation and your enthusiasm and all the wonderful sharing and networking that we do as a community. Keep that going, because it is really patient-powered research. And if anyone does want any of the references from this talk as well, please just let me know and I will send those through. And that's pretty much it. Yeah, any questions? I'll throw back to Lauren now.
Hi, so thank you so much for that, Kate. We have a bunch of questions, and some of them probably don't have answers because there just isn't a lot of research, but I think it's still good for us to go over them, and you can address what we have research on and answers for and what we don't. So here's a kind of a good generic question to get us started. If you're planning to get pregnant with POTS, should you just wing it, or should you sort of talk to your doctors and kind of come up with a game plan in advance?
Definitely the game plan. And in saying that, even if people listening, if you're only a teenager or if you're mums of teenage daughters with POTS, these are all things that you should even be thinking as well. I'm not advocating pregnancy in the teenage years, but all our medications that we take, all the medications for POTS will have some sort of effect on the body. So even just thinking in the back of the mind, you know, I might want to have a baby in 5 or 10 or 15 years. How will this medication affect me? So definitely make a game plan. Definitely talk to your primary care physician, your cardiologist, whoever is looking after you from a POTS perspective, and also see a high-risk obstetrician even before conception. They are fabulous resources for all things maternal fetal wise. They'll know which medications are good ones and what will be appropriate. So definitely set a game plan. If you wing it, you know, I'm sure that will also be fun as well. But if you do have the time and the ability to set that game plan, even if it is looking at maybe thinking about falling pregnant in years' time, think about it now and talk to your doctors about it now, because particularly if you have male doctors, they just might not even think about it. So it is really well worth setting a game plan and asking.
Okay, our second question is sort of two parts. The individual asking the question says that she has shortness of breath prior to her period. She wants to know if this gets worse during pregnancy, and is shortness of breath normal in POTS? So I'm going to actually quickly take the first part of that question. I think, you know, we can't give individualized medical advice on here because, you know, that we don't really know any of you, and I'm not a doctor, and Kate's a nurse in Australia, so we're not giving specific medical advice. But the general concept of patients having more symptoms right before their period or more shortness of breath, your body, your hormones change at different times in the month. Not only your menstruation-related hormones, but your hormones that regulate your blood volume. And you can become a little bit more orthostatic, have a little bit more blood volume issues prior to your period, not actually because of blood from your period, but actually just hormones that regulate your regular blood volume. So yes, shortness of breath before your period is not uncommon in POTS, and some patients get it throughout the month. And then I'll kick it back over to Kate for the second part of that. Does that get worse during pregnancy?
The short answer is possibly yes. But you have to remember as well that a lot of symptoms that we find in POTS, so the feeling dizzy, the feeling short of breath, the feeling tachycardic, the getting the palpitations are actually normal pregnancy symptoms. So somebody without POTS, a normal, healthy, sick prior to pregnancy person may actually feel all these things too. So yes, you may get more short of breath during pregnancy, but it may or may not be related to your POTS. And it may be exacerbated because of the presence of POTS, but it is all very it's all very common and can affect anyone. And like Lauren said, it has a lot to do with the hormones and the fluid shifts in particular with pregnancy, and also your baby squishing your diaphragm. Even when they're quite small, the uterus can come up. So yes, you may get short of breath in pregnancy, but it may or may not have anything to do with POTS.
The next question is about ivabradine, which you did mention during the chat, but I think it's worth reviewing because it's kind of an important one. This person is asking, she says, I know it isn't recommended in pregnancy. Are there any effects on the mother or the baby? And is there any replacement medication if you're on ivabradine and have to go off it for a pregnancy? Is there anything your doctor can do?
So currently, ivabradine is a run for the hills kind of medication in pregnancy. If you have a doctor or a specialist that recommends that trying it, I suppose you can, but certainly double check what is known about it. And I can't remember what it's called in America, but there is a MedSafe and Pregnancy Safe. There's a few different websites. The FDA and the TGA here all have information on what is currently known about medications, and at least here in Australia, it's a Class X drug, and it's a don't even try. So the research currently, from what they know from animal studies, doesn't show particularly nice things happening to the mother or baby. So personally, from my personal and professional opinion, I wouldn't be going anywhere near it until we have a lot more data in pregnancy. In saying that, you can trade out ivabradine for some other medications. Beta blockers are the most common ones that I've seen patients be switched onto, like propranolol, metoprolol, and atenolol. And atenolol is one of those funny ones that some people really like and some people don't. But beta blockers, generally speaking, have very similar safety profiles and classes, and ivabradine primarily works on your heart rate, and beta blockers can help in that. They don't work as well if ivabradine is something that works amazingly well for you. Beta blockers certainly won't take the edge off quite like ivabradine, but for safety in pregnancy it might be well worth it. But certainly something to talk with a high-risk obstetrician about in particular.
The next question is about exercise during pregnancy. It comes from a prenatal yoga instructor, and she says, I'm assuming it might be a he, but this person says they want to believe that exercise can benefit pregnant patients, but she's curious if POTS plus Ehlers-Danlos syndrome plus exercise might be too much to ask of a pregnant woman. Your thoughts on this?
I, particularly with the EDS thrown in there, I can't really comment because that's taking it out of the realm of my expertise. But I would think talk to your physicians, your treating physicians, and they'll be able to let you know what might be appropriate exercises and what level of exercises would be really beneficial during pregnancy. All exercise is good for anyone, but it's just finding the right kind of exercise at the right stage of pregnancy to suit your individual needs. Sorry, that was very vague.
No, I think that's a fair answer. I actually want to add to that too. You know, as patients, we're often told to exercise, and that exercise can mean a lot of different things to different people. If you're doing a, insane cardio workout, 3 hours on a treadmill, that's one kind of exercise. But sometimes just kind of, doing some gentle calisthenics on your floor in your den. Exercise doesn't have to be a big, sweaty Jane Fonda workout. dating myself because the younger kids don't know who Jane Fonda is. But you know, exercise is just moving your body, engaging your muscles, getting your blood flowing. So whatever your health situation is, you should be getting some kind of exercise with some guidance from your medical providers on what the appropriate amount is. But I do worry that if someone was pregnant and just completely avoided exercise, that they actually could become deconditioned, which could worsen their orthostatic and other autonomic symptoms. So it's really important to talk to your doctors to figure out the right way to exercise, whatever your situation, pregnant or not. The next question. Should a POTS patient see an endocrinologist if they have an irregular cycle, even on birth control, and your primary care can't figure it out? I think that the person asking this question probably knows the answer is yes. But
yes, I agree there. Yes.
You know, it's hard for us to know when to bounce to new doctors or when to stick with the team we have. But if you have sort of an unusual problem that's not responding to normal treatment and your primary can't figure it out, you know, maybe talk to your primary, ask them if they think that you should see a endocrinologist, or if there's anyone in particular that might be a good type of doctor for you to see. And it may not be an endocrinologist. They might want to send you to, you know, a gynecologist who might specialize in this type of thing.
I think that's probably right with all POTS kind of related things. Whenever we get symptoms that are either new or just different and our primary care physicians don't know, sometimes it is actually really good to get another opinion, as much as that's hard going through the whole what is POTS kind of scenario. But it's very easy to put all sorts of strange symptoms or different things down to, oh, it's just POTS, or it's just autonomic dysfunction. So if there is something different going on, it is probably important to get it checked out by a specialist just to make sure that it isn't something else.
Right. Here's a question that seems straightforward but may not have an easy answer. What is the most common delivery method for women with POTS?
Well, from our very limited literature, it's vaginal delivery, and clinically there aren't very many patients around here that I've seen, but the couple that I know of, I think one was a vaginal delivery instrument assisted and one was an emergency cesarean. There was another emergency cesarean, one was a planned cesarean. It really depends on the patient and what the pregnancy's been like, and the different symptoms, and also the specialist and what they're comfortable with. Some doctors, it will seem, want more control, so having a planned cesarean will give them that control with an early epidural, and also help them monitor hemodynamic state. But if you're really pro natural or vaginal birth, it certainly has been seen in our limited evidence, but from anecdotal clinical practice, it is doable. You just need to make sure that you have an appropriate management plan. So whatever thoughts you have on what kind of delivery you'd like, make sure you talk with your midwife, obstetrician, primary care physician, and anaesthetist to make sure that you've got all the appropriate things in place and you know when things may need to escalate for your own headspace going into delivery.
So the next question is, do we know why some patients feel better during pregnancy? Is it the increase in blood volume?
We don't really know exactly, but it's certainly thought that it's probably got a lot to do with that. Certainly increased blood volume if you're hypovolemic, which we know a lot of POTS patients are, is going to be beneficial. But yeah, we don't really know why. Sorry. Lots of vague answers here.
Blood volume sounds like a good guess. But I'd also add to that, something that we're still getting early research on in POTS overall is that when you're pregnant, your body has a lot of immune system changes too. I mean, really, your autonomic nervous system works a little different when you're pregnant. Everything is different when you're creating a new human being inside of you. So it could be blood volume. It could be a combination of immune system changes and neurological changes and neurotransmitter changes. We don't know, but that would be wonderful if we could figure out what it is and then kind of give it to ourselves all the time so that we're benefiting from whatever it is that makes people feel better.
No, we could induce everyone into a permanent fake state of pregnancy as a treatment for frogs. Yeah.
I did have a doctor tell me when I was first diagnosed, oh, if you get pregnant, this will go away. And I thought, oh, wishful thinking, buddy. So maybe that happens to some people, but probably not. So here's another question. Does the increased heart rate have an impact on the fetus?
Potentially, yes. But again, that's a fairly general kind of obstetrics issue. So anyone that's got too fast or too slow a heart rate, or their blood pressure is too high or too low, obviously can affect the baby, and all of the management for that will depend on your individual situation and what your baseline is. So if the baseline is normally at 90 or 100 beats per minute and you're slightly tacky at 110, and the cardiologist and the obstetrician are okay with that and you're monitored, it may be okay. But for somebody else, if their baseline is like 60 and they're now sitting around 100, it could be normal pregnancy, because tachycardia and increase in heart rate during pregnancy is normal. But it could also be a POTS thing, and certainly something to talk to your doctor and obstetrician about to find out what's right for you and what your team are comfortable with. So again, very individual.
I'm sorry, I cut you off. I didn't know. I thought you were done.
That's right.
Does Zofran have any connection to birth defects?
I don't know. I know here in Australia that Zofran is used in pregnancy, particularly with hyperemesis governor. So I can't actually remember what the class of drug it is considered here. It's certainly not. I mean, Zofran in general is hard to get, but yeah. It seems to be approved for some sort of use in pregnancy, but I'm not actually entirely sure, sorry.
There's a couple of questions about the safety of getting an epidural when you have POTS or when you have EDS. And maybe the first thing you should explain is really give people who may not know what an epidural is, just a brief explanation of what that is. And I would say, even if I don't know off the top of my head what research is out there, but anything sort of involving your spine, in EDS in particular, I would be extra cautious about, because we know that some patients have, they're more likely to have CSF leaks. Their dura that contains their CSF fluid isn't maybe as resilient as we'd want it to be. So this is sort of a kind of a new area, and not very new, but still being explored area in EDS-related research. I am kind of answering the question, but go ahead and answer the question, Kate. I think it's actually a very interesting subject that needs to be studied.
I wholeheartedly agree, and pretty much from my limited EDS knowledge, that's all that I was thinking as well. I agree with you, Lauren. It seems, from my limited research and understanding of EDS, epidural may cause, or there may be higher rates of CSF leaks and poor healing. But in regards to POTS and epidural, so an epidural is where they put a little bendy plastic catheter into the space in between the dura, which is the outer coating of your spinal cord, and just in between that there's 3 different layers before you get to your spinal cord itself. So it's just a little bendy needle that they put into that first space, and they put in local anaesthetic, which will numb you from that point down. It seems in the literature, it was interesting actually looking at how many of the studies addressed anaesthesia and analgesia. I think anaesthetists are quite keen on reporting case studies, which is really handy for us. It seems that epidural is safer than a spinal block because of the way the medications work, and epidural can actually give more hemodynamic control, particularly in relation to pain as well, because pain affects your blood pressure. But yeah, it seems that epidural is actually probably potentially a good idea considering in POTS, just from that control point of view, and from a safety point of view, because anaesthetics affect people differently, but particularly when you've got nervous system disorders, knocking out part of your body or your whole body in a general kind of thing can sometimes not be so great. So yeah, something to consider. I hope that answered the question.
There was a more general study on pediatric surgical outcomes in POTS that was about, patients who had received anesthesia. And these were sort of minor surgical procedures, and they suggested that if a patient had had a procedure, that there should be a scheduled follow-up, maybe like 2 or 3 days later, because patients who often have these, same-day procedures where maybe you have a colonoscopy and then they ship you home later that day, they would have sort of, some of them were having POTS-related flare of symptoms within a few days after that. And instead of the patient ending up in the ER, kind of in an urgent care, needing help right away situation, the doctors suggested that, having a planned visit may help avoid an ER trip and just make sure everything is going smoothly afterwards. So I don't know if the same would apply to pregnancy, but I think if you have any kind of anesthesia, that would be considered. And certainly a pregnant, a delivery is usually more of a stress on your body than like a colonoscopy would be. So just something to think about more generally, to make sure you're not popping out the baby and going home that night and not seeing your doctor for a month, Yeah,
don't do that. Please follow up with somebody.
Here's a good question. Are the high doses of salt that we use in POTS safe during pregnancy for the baby and also while breastfeeding?
Short answer, I have no idea. And that's something that you'd have to be discussing with your individual care teams. And high dose for one person is quite different to high dose for others, or at least in Australia. I know the American Heart Association or the Australian Heart Foundation wouldn't like the high salt diets, but yes, don't know, there's no data on how that affects it that I have seen.
Someone added a comment after our Zofran question before, noting that Zofran is no longer recommended in the U.S. for pregnancy. It was associated with some sort of birth defects. So I can't confirm this for sure, but definitely look it up before you get pregnant, and certainly talk to your doctor if you use Zofran regularly. Maybe there's something else that can help you with your nausea type symptoms.
That's interesting. Thank you. I will look that up as well for Australia.
We learn from each other, right?
Indeed.
Is it safe to take daily lactated ringer solution during pregnancy? I don't know. Kate, do you have any info? I don't think this would have been in any of your studies.
There's definitely nothing in the studies. I think the biggest thing with having regular infusions during pregnancy would be the same with regular infusions at any time. It would just be the infection risk. But Ringer's lactate is, we use that in all sorts of situations. But yeah, I don't know. They certainly didn't address that in the papers.
Yeah, I think it's probably frustrating for you guys listening to hear, like, we don't know. But the reason that we're saying that is because there really hasn't been enough research. And I love that Kate is bringing this up and addressing this issue and publishing a journal article that says, here's what we know, here's what we don't know, here's what we need to know. That actually can lay the groundwork for other researchers to do more research, Kate and her team, but maybe at other institutions as well. And it also helps get funding, because now that there's been a systemic review of the literature, we could go to our federal funding agencies and say, this is a grossly undermet need. We have no idea. We're basically winging it when we send.
We are winging it, yes.
Do all these, and we say, ask your doctor. Your doctor's not going to really have the clear answer either. They are going to be going on their best clinical judgment and knowledge of your situation. But we really want to get to the point where there are clear clinical guidelines on what's safe and what's not safe, and what's the best approach to help you through this, as smooth a pregnancy as possible. Because, being able to conceive is important to a lot of people, and we don't want people to be afraid of it, or have to suffer with, unnecessary symptoms that might have been preventable. So we're wrapping up. It's around 10 p.m. here. I'm not sure what time it is in Newcastle, but I know that Kate has some traveling to do today. So do you have any last thoughts you want to leave us with, Kate?
Just know that it's frustrating for us as well to not know these things. So we definitely take everybody's thoughts and all the wonderful questions and opinions and thoughts that have been thrown at me through email or through the conference, wherever, I really value, and they certainly are helping our research. And if you can just pass the word on, get the message out there, and pass the review on once we get the details out. And certainly, push for funding. We need more research. And you're all amazing. Don't forget that.
So we will send out an email to everyone with the recording of this webinar. Give us a few days to pull it together. And we'll send a link and some information on Kate's studies for patients and for medical providers. If you know other POTS friends who would meet the study criteria, or you have any medical providers who you see that have managed you or other pregnant POTS patients, I know Kate would love for them to participate. Getting their feedback is just important as getting patient feedback. So be on the lookout for the email in a few days, and thank you so much for joining us.
Thank you, everyone.
Bye.
Bye.